Yes, Dr. Sirisha, please start.
Yes. Good evening, everyone. Management of canalicular injuries, no financial disclosures, the anatomy, the puncta, the canaliculi, common canaliculus, lacrimal sac and nasal lacrimal duct. Eyelid lacerations commonly present with canalicular involvement and requires a stent to prevent canalicular obstruction. Medial upper and lower eyelid injuries often result in trauma to the lacrimal system. Road traffic accidents are common causes of ocular trauma and eyelid injuries. Canalicular injuries can be direct or indirect. Direct, glass, coat hangers, knives, dog bites, cat claws, fingernails, hook injuries and other sharp object injuries. Indirect trauma includes blows to the face, blunt weapons, and due to fall on the blunt objects. Hezram and associates reported injuries of the lacrimal drainage system in 16% of the eyelid injuries. Fayette reported that canalicular lacerations are associated with 20% incidence of globe injuries. Canalicular injuries are most common in children and young adults, more in the inferior canaliculus and the horizontal lower limb. Injury to the lacrimal drainage system leads to scarring and stenosis, which leads to epiphora. So in the setting of acute facial trauma, attention must be given to the following order: life-threatening conditions like head trauma, vision-threatening conditions, particularly open globe injuries, canalicular trauma. A complete ophthalmic examination must be performed, which includes visual acuity, pupillary reaction, extraocular movements, intraocular pressure, external examination, slit lamp examination, and dilated fundus examination. We should assess for the tissue loss, canthal ligament injury, tetanus vaccination, check for rabies vaccination in case of dog bites, medico-legal implications in road traffic accidents. The patient should be put on broad spectrum antibiotics and pain relief, NSAIDs for pain relief. The outer end of the laceration is easily identifiable with a Bowman's probe, but the inner portion of the canaliculus is often more difficult to identify. Canalicular laceration can be identified by direct observation of a laceration medial to the punctum, probing with Bowman's probe by irrigating cannula, irrigation of the intact limb of the system. Isolated eyelid lacerations with otherwise normal ophthalmic examination don't necessitate immediate imaging. In patients with suspected orbit or midfacial fractures penetrating foreign body, CT is done. Fractures may require complex surgical repair that is ideally undertaken prior to addressing canalicular trauma. Dactylocystogram may be confirm the disruption of the lacrimal drainage system. The surgical management includes repair of the canalicular injury under LA plus MAC or GA. Immediate repair of the laceration with stenting of the canaliculus is the most preferred treatment approach. When performing lid laceration repair, first priority should be given to the adequate protection for the ocular surfaces. The surgical methods include direct anastomosis of the lacerated end of the canaliculus, pigtail probe and silicone stent, monocanalicular stents, bicanaliclar stents. Direct anastomosis is with 80 Vicryl suture. It can be combined with intubation for the patency of the canaliculus. The pigtail probe is inserted into the uninvolved canaliculus and rotated until the end of the probe was visualized in the nasal end of the tone canaliculus. A silicone stent was then inserted which connects the two canaliculi. Monocanalicular repair is the most preferred choice, and it is the stent is secured by the punctum by the plug, and no knots or suture are necessary, even though some surgeons prefer to secure it with a suture. Bicanalicular repair is with the two mini Monaca stents for the two canaliculi, Crawford stents and Rittling stent. The stents are removed at around 12 weeks. The mini Monacas are removed by gently pulling with a forceps from the puncta. Crawford's and Rittling stents are gently removed from the nose, and pigtail stents are rotated so that the knot is externalized out of the punctum. The suture is cut at the knot and the stent and suture are pulled free. Management of canalicular injuries at a hospital. And this is a case of a 1-year-old boy who was injured with a pencil tip. We managed with mini Monaca and the patient did well. This is a young lady who was hit by a spoon, and at that point of time There was no mini Monaca or any other stents. So we managed with the 24 gauge pediatric IV cannula, and the patient did anatomically and also functionally well. This is a canalicular injury by the dog bite, and it was secured with one arm stent for canalicular laceration. This is another case which was managed with mini Monaca. To conclude, canalicular injuries are common in children and young adults. Repair using mini Monaca stent within few hours of injury gives excellent anatomical, functional, and cosmetic results. Thank you.
Thank you, Dr. Sirisha.
Thank you, sir.
Can we have the next, any questions? Dr. Sunil, please.
So I wanted to start with thanking APOS and AOS, but I want to thank the people sitting in the room for attending this. Thank you. So art is long and life is short, and refraction is indeed an art. So as this topic is about subjective refraction and the way I do it, so it could be subjective. That's a disclaimer. So what is infinity for human eye? Infinity for all universe is galaxies and galaxies away, but infinity for human eye is just anything over 20 feet is infinity for human eye. And from infinity to the near point, at every point you need some sort of accommodation, so refraction is dynamic. So where to start? Obviously vision, but listen to the patient. He is telling you his intent, or especially the female patients, their intent to use or their dislike for the specs. So it's most often it happens is certain patients come together and say that their headache will go away with specs. Indeed, you are dealing with a refractive patient. And most of the times, the patient not knowing the optotypes is the one of the most important common cause of defective vision. They won't reveal it, but once you literate Snellen charts are used, they won't. They say that they couldn't see, and when you press, they will say that their formal education is not there. So, and present glasses of the patient are one of the most important point to start the refraction. So I will be dealing with under these subheadings. It's machine myopia, pseudo myopia, and night myopia. So what is machine myopia? The typical case scenario will be a young boy will come for a routine checkup, but the machine throws up a reading of -5, -6, -7 readings. If you just see bilateral visual acuity, it will be 6/6. So, and once you take repeated readings, the initial high readings of minus will go away. And the second most important point, important thing I want to discuss is pseudomyopia. So the typical patient will be like this. Again, students, after reading for some time, they're defective and the distant vision becomes defective. So, and certain patients, they come for headaches. So how do you recognize these patients? Again, the manifest refraction will be more than what they could read unaided with both eyes open, and cycloplegia will reveal this. But again, how do you correct them? So basically, they will be happy with certain minus power. Their defective vision won't go if you don't give a minus power. So curtail it to a minimum extent. Give a cycloplegic drop at the night time, and curtain the near work. Let them ask them to take breaks. And night myopia, I don't have any experience with it. Some people require a degree more of high, a bit more diopters at night. So hyperopia, again, the most of the times, though it's called long-sightedness, they present with defective vision for distance. So, and most common cause is brow-ache and frontal headaches. Automatically warrants cycloplegia. Again, will the patient accept? So though the teaching is to give the maximum plus, the patient may not accept it. Try, give a minimum plus, and gradually as the accommodation relaxes, then they will accept. So astigmatism, another most important cause of ophthalmic headaches. Present glass, they are treasure trove for astigmatism. You just don't tweak too much of axis or the cylinder from the present glass. And sum total and astigmatic axis in most patients will be 180 degrees to each other. So use this principle. So once you can fix one axis, the other axis will be 180 minus that, and most of the times the patient will accept that. And prescribing the cylinder for the first time in an older patient, more than 20 years old, don't give more than 0.75 cylinders. Just adjust the spherical equivalent, and keep the trial frame on and ask the patient to move about in the OPD, and that's called the trial run. And if you can't accept that then and there, then he may not accept afterwards also. So presbyopia, again, don't go by rule of thumbs. Ask the patient to what he does and what his near distance, what is near vision, what is the near working distance is. So, and confirm the actual accuracy of distant correction. And again, don't tweak too much with the present glasses. For the patient who comes with a routine, for the routine checkup, don't give more than 0.5 to 1 diopters more than the present ad. And most of the times the patients will be comfortable, illiterates, they will be comfortable without the bifocals. Actually, that's an hindrance for them. And in routine camps, what happens is they give plano by +3, which is a hindrance for them. And remember that bifocals are one of the main cause for falls in the elderly. So, I mean, progressive additional lens, these are, apart from aesthetics, they fill a very, they fill a void that is not treated by bifocals. That's the intermediate vision. So, but the pitfalls are costs and needs for the adjustment. For example, if the patient is already using bifocals, or if he's having significant astigmatism, progressive additional lenses may require some time. And the and the other thing is, routinely with classes, what we do is we turn our eyes to see things, but with the progressive additional lens, we should turn our head sideways or up and down to see things. And another tip I want to give is the ad in the progressive additional lenses will be a little bit more than a routine bifocal, because the very moment you hit the near segment, you don't get the total power. So give a little bit more ad in a progressive additional lens. So cycloplegia, when to do it's a must. Of course, anyone below 12 years, it's a must, you do. And patient consent is very important. For example, don't take it lightly. I have seen fights erupt in OPD because we have not mentioned that, and the patient has got incapacitated, he has to go somewhere else. So take patient consent, and when you don't get adequate cycloplegia, don't keep on increasing the dosage. Just increase the strength of the drug, or skip the drug altogether and go for a more powerful drug. And they do have side effects. I have seen children getting delirious after cyclopentolate. And post-cycloplegic test, is it required at every point of the time? Post-cycloplegic test is not required. Sometimes, as a benefit of doubt, you want to do cycloplegia, but you can do one thing. You can prescribe the glasses subjectively, do cycloplegic test, and there are no great surprises, just prescribe the glasses. And refraction in children, of course, you know that hyperopia may correct over a period of time, and mild myopia need not be corrected, but any refractive error beyond the age of 6 should be fully corrected. And constant use of glass is recommended, definitely in case of exophoria, and even for near reading, because to accommodate to convergence, to encourage that, you ask the patient to use the glasses constantly. And this one point I have seen so many patients. Anisometric amblyopia occurs pretty commonly in hyperopes and asymmetric hyperopes, and they will be blind for life. So catching them early and treating them will be a great boon, more than cataract surgery. So 6/6 and N6 is not the holy grail, but the patient's comfort in day-to-day activities are holy grail. So it's an art of, it's mostly about first impressions. The subject to refraction, the moment you put a glass, you know that whether the patient is liking the glass or not. So it's all about first impressions, and don't be tough on yourself and the patient. And one trick is, if the patient is still nagging that he is not able to see clearly 6/6, just show him with both eyes open. Bilateral visual acuity somehow will be better than each individual eye. I don't know the reason, maybe simultaneous macular perception or something, but it'll save many headaches and chair time. Thank you.
Excellent presentation, Dr. Sunil, and informative tips which we encounter day in, day out, every day in the OPD. Can we, do we have Dr. Padmini here? Dr. M. Vivekanand Reddy? Not there. Okay. Should I go in? Dr. Pawan? Dr. Pawan, will you present? Inviting Dr. Pawan for his topic on ROP screening update. Madam, you can leave. That's not an issue. Please. No, not an issue. Problem.
Excuse.
Duplicate screen.
Sir?
Please duplicate.
How, sir? How to share?
It's a Mac.
Hmm.
Come on. Okay. Just you open and
Excuse me. Good evening, everybody. I'll be speaking on the updates of retinopathy of prematurity. My references are from which one? This one? Coming full screen. My references are from American Academy of Ophthalmology, International Classification of ROP, which was released in 2022 October, and National Neonatology Forum, their guidelines released in 2023. As we all know, coming to the zones, the posterior most part is called the zone 1, and anterior most part is called the zone 3, and the central part is referred as zone 2. Now, International Classification of Retinopathy of Prematurity has added another zone, that is posterior zone 2. Reason for addition of this new zone is that the more posterior the disease is, the more aggressive the disease is. So that's the reason why they have again subclassified zone 2 into two regions, anterior zone 2 and posterior zone 2. Coming to the normal development, by about 16 weeks, central zone 1 is vascularized, zone 2 by 8 months, zone 2 is vascularized, by 9 to 10 months, the whole retina is vascularized. Stages and their updates, the first one remains the same. In stage 1, a clear-cut line develops between the vascular and avascular retina. In stage 2, a ridge-like structure develops. In stage 3, a fibrovascular structure develops from the ridge. And in stage 4, retinal detachment, which is subtotal, develops. Here, International Classification of Retinopathy of Prematurity has classified stage 5 into 5A, 5B, and 5C. In 5A, we can see total retinal detachment. In 5B, we can see a closed funnel retinal detachment. And in stage 5C, we can see anterior segment findings like lid edema, conjunctivitis, corneal edema, and then white pupillary reflection. And this is one interesting development in the International Classification of ROP. There, they have completely changed the earlier term called aggressive posterior ROP. Now there is nothing like aggressive posterior ROP, it's just aggressive ROPN. The reason behind aggressive ROP is not just posteriorly, and it is also seen anteriorly. So now they have completely abolished the term AP-ROP. Coming to the screening criteria of ROP, these are the neonatal forum of India, which were introduced in 2023. All the babies born below 34 weeks of gestation, babies born below with birth weight less than 2000 grams, and babies born between 34 to 36 weeks of gestation with any of the risk factors. Coming to the significant risk factors which are released by National Neonatology Forum, malnutrition, respiratory distress syndrome, and blood transfusion are the highly significant risk factors in India. Anemia of prematurity and pregnancy-induced hypertension are the significant risk factors in Indian population. As we know, the mechanism of ROP in RDS, there is lung atelectasis, there is decreased lung complaints, baby goes into hypoventilation. To substantiate it, we take the baby for external oxygen supply, there is hyperventilation, then cessation of vascularity, and then RDS develops. In blood transfusion is now considered the second most significant factor for ROP. In stored blood, there is an increased iron load. This leads to oxidative stress, and this leads to increased oxygen delivery to the tissues, and this in turn leads to ROP. In malnutrition remains the third significant factor in India. This malnutrition leads to decrease in the levels of insulin-like growth factor, which is necessary for the normal development of retina. Coming to pregnancy-induced hypertensive conditions like preeclampsia, eclampsia, and in HELP syndrome lead to vascular compromise in the developing fetus. Maternal systemic infections lead to decrease in the insulin-like growth factors, which in turn lead to ROP. And the most interesting factor which has been published by International Classification of ROP in 2022 is proteinuria. Embryologically, retina and the kidney share the same embryological development. So, proteinuria is also noted in patients suffering with ROP because of the underformed glomeruli. They lead to proteinuria. These are the few insignificant risk factors. They are very significant. These insignificant risk factors in Asian population are highly significant in the European and American population. They are highly membrane disease, patent ductus arteriosus, hydrocephalus, hypoxic ischemic encephalopathy, intrauterine growth retardation, birth asphyxia, premature rupture of membranes, and pregnancy-induced hypertension. When to screen? First screening should be performed at 4 weeks postnatal age. In neonates less than 28 weeks of gestation or birth weight less than 1,200 grams, our birth age is not confirmed conclusively. ROP screening to be preponed to 2 to 3 weeks postnatal age. Treatment, as we all know, it's either through anti-VEGF injections or retinal ablations. Interestingly, in ICROP study which was released by American Academy of Ophthalmology, they have mentioned reactivation of ROP post-delivery. These are the two images which have been reported by American Academy of Ophthalmology, where in the pick 1, baby had taken intravitreal bevacizumab in 32nd week and 36th week. But in 67th week, the baby had again developed ROP. And this is a second baby where baby had taken a single dose of bevacizumab in the 36th week. But later at the 50 weeks, the baby had again reactivation of ROP. Coming to my take-home message, National Neonatology Forum declared that in premature babies, prevalence of ROP has almost reached 37%. But even today, diagnosis and management of ROP is still a tertiary care decision. So, need of the hour is some artificial intelligence-based tool, like how we use a sphygmomanometer for blood pressure. We need some artificial intelligence-based tool or tool which is easily available, simpler, and which can be handled by even a technician to diagnose ROP. In Europe and America, we have WinROP, which has almost all 97% of accuracy, but the systems which are developed in India have the accuracy up to 90% only. So, they are not so trustworthy. So, this is my conclusion. Thank you.
Thank you, Dr. Pavan, for this excellent updates. It's a very important topic and very niche topic also. Very few people do this ROP screening. And it's important that we understand how things work, and we have to be up to date in terms of the screening protocols. Thank you.
Dilatation percentage.
Dr. James. एक फोटो ले लोगे क्या? फोटो एक तो ले लो. Okay, shall we start? Yeah. Good evening, everyone. And even though we are a very small group left over, my topic for today is anti-VEGF in DME, diabetic macular edema. My disclosures are, I have taken few slides from Bayer, Novartis and Roche. Now everybody knows that diabetes is something like a pandemic. We've just gone over coronavirus, and again diabetes is there lurking on over our heads. From 2019 to 2045 it's going to increase exponentially. And as diabetes increases, the number of diabetes increases, so will diabetic retinopathy and diabetic macular edema also. Now, questions to answer while treating: when to start therapy, choice of anti-VEGF, which protocol to adopt, what would be the endpoint, factors to consider that may affect response to therapy, and when do we consider combination therapy and studies. Just going on to the history and how we have evolved over the years for DME treatment. At one point in time, there was no treatment available for DME pre 1980s. Then came laser photocoagulation, then steroids, then anti-VEGF therapy, and different types of anti-VEGF therapy along with steroids also. Now there are different types of anti-VEGFs that are available. First came pegaptinib, ranibizumab, aflibercept, brolucizumab, and now the new kid in the block about to be launched. Bevacizumab was not FDA approved, even though studies have been done. Now there are two types of studies that we have to consider. One sponsored by the industry and the other by the academics. Now DRCR net is something which we need to keep in mind. What are the lessons learned? Do we consider vision when we treat? Yes, study the protocol we showed that we can wait and watch instead of going ahead and treating either with laser or anti-VEGF, aflibercept. But 1/3 of patients were switched on to injections and 2/3 maintained good vision without treatment. So we did not jump in to say that okay fine, if I see diabetic macular, if the OCT findings are there, then immediately I have to treat. Now OCT classification, one thing is, now everybody would have known that center involving diabetic macular edema and non-center involving diabetic macular edema. The other thing is tractional, non-tractional. In that again we need to divide whether there's a decrease in vision or vision is being maintained. There are certain OCT biomarkers which we need to consider. One is ERM, vitreomacular adhesion, drill, intraretinal hyperreflective dots, ellipsoid zone disruption, intracystic hyperreflective material, ELM integrity, foveal eversion, and retinal artery macroaneurysm. Coming to few studies, I would just rush through them, not go into details. Now, protocol I is something which told us whether we need to give ranibizumab along with deferred or immediate laser. Even though there was an improvement in vision, but ultimately there was not much difference whether you defer or give immediate laser along with ranibizumab. So the one line that we should learn from this protocol I is the anti-VEGF therapy with monotherapy with ranibizumab is enough, and we need not do laser immediately. This is one study which has guided us to choose between the three anti-VEGFs, that is bevacizumab, aflibercept, and ranibizumab. And this has shown that aflibercept does well when compared to bevacizumab or ranibizumab in year 1, and it continues, but there is not much statistical significance between the two in terms of visual gain at year 2, between aflibercept and ranibizumab at year 2. Now aflibercept was associated with rapid or robust anatomic changes that were superior to those observed at year 1 and maintained through year 2. So the decrease in central subfoveal thickness was better with aflibercept compared to ranibizumab, and the least was with bevacizumab. The number of lines, the number of letters gained with Eylea was better compared to ranibizumab or bevacizumab. So aflibercept maintained a superiority over the other two drugs. Now just to touch upon brolucizumab, which is the new thing, and that has shown good results. The drying effect of brolucizumab is much better, but there are other side effects which we need to consider, especially the vasculitis. The newest drug that we have is faricimab, which is yet to be launched, probably by December. We need to wait and watch. It's an exciting thing, but we don't know how it fares well when it comes to clinical practice, which is the most important thing, and the cost of the drug. So there are studies which have been done for AMD and DME. So the Yeshomite and the Rhine are for DME, and that has been compared against aflibercept. This has shown good visual gains as well as drying up of the central subfoveal thickness reduction well with faricimab compared to aflibercept. There were not much adverse events which are seen with faricimab. So these are the different types of anti-VEGF agents which are available in the market. We need to choose what is the best for us. Take home message: don't be in a hurry. Consider the vision. Visual acuity is good, we can wait. But if it is worsening, then we need to think whether we need to treat or not. OCT parameters, few things that we need to take into consideration. The biomarkers especially, so that we can counsel the patient well before we treat them. That's the most important thing. And not that if aflibercept has shown better results, we need to look at the pocket of the patient also, whether the patient can afford it. So affordability in Indian scenario is something good that we need to consider. Even though the fixed regimens as per the studies, if we exactly follow the treatment protocol as per the RCTs or the studies, they show good improvement, but not necessarily that we need to follow them exactly how they have done in the studies. Type of anti-VEGF we need to consider depending on the multiple parameters. Communication and counseling the patient is the most important parameter that we need to look in before we go ahead and give any anti-VEGF. Thank you. Correct. So there are few where Indian population also have been considered. More than anything, more than these studies which are sponsored or done by the companies, we should be looking at, especially for DME, drcr.net. So they are more, I would say, more genuine, authentic, than there won't be much bias. So now I request Dr. Venu to present on evaluating a case of uveitis. That would be the last talk.
Okay, good evening everybody. So this topic, I'll just summarize because it is a very huge topic. So I'll go through fast. So a non-selective elaborate approach is not required for a case of uveitis. Usually we go on doing all investigations available to know the cause of inflammation, but it doesn't require that. And all these investigations are more supportive, they don't confirm any diagnosis. And before investigating, going for lab investigation, we need to know how far the investigation is sensitive and specific. And main thing is in workup, the history taking. Usually we miss this. Once we have come to ophthalmology, we forget about the history taking. So history taking is very important, and complete ocular examination and physical examination is required. So with respect to age, once if suppose a child comes, then we need to think in terms of infective, and immunological is JRA, infective is toxocariasis. And middle-aged young adults think of autoimmune conditions like HLA, B27, Behçet's and Fuchs. And old age, again infective comes into picture, VKH, herpes, tuberculosis, leprosy. So these are the patterns which the etiology distributes. In male, if you think it is more in terms of ankylosing spondylitis, Rettus, Behçet's and sympathetic ophthalmia, as they are more prone for injuries. Male are more prone for injuries. And females, again, it is immunological, rheumatoid arthritis, JRA. And systemic conditions. If suppose patient has any autoimmune conditions like collagen vascular diseases, Behçet's, Rettus and VKH, these are all autoimmune conditions which we need to rule out from infective conditions like tuberculosis, toxo, post-viral infections. So post-viral infection can be mostly immunological indirectly, but the triggering event is viral infection. And immunosuppressive individuals, more common is endogenous endophthalmitis. If symptoms, if suppose patient present with pain and photophobia and redness, it's more of anterior uveitis. If he comes of floaters and decreased vision, it is more of intermediate and posterior uveitis. pain on ocular movement, think in terms of posterior scleritis. And sudden bilateral vision loss is more in terms of bilateral inflammatory condition like VKH or sympathetic ophthalmia. So extraocular examination, if the patient has poliosis, think in terms of VKH and sympathetic ophthalmia. Erythema nodosum in case of sarcoid, Behçet's and tuberculosis. And cartilage loss, if patient has any nasal bridge loss or change in the architecture of pinna, think in terms of polychondritis and leprosy or vaginous. And pitting of nail bed is more common in psoriasis and ritus, and oral ulcerations in ritus and Behçet's. So this is a systemic examination. There are many other conditions. So here is a small example. A 25-year-old Indian farmer male comes with acute non-granulomatous unilateral anterior uveitis with hypopyon and past history of fever and jaundice. He has also occasional pain in hip and he has urethritis. So this is a short history. So with this we need to go for what could be the possible diagnosis. So first of all, history, demography, like he is an Indian and his occupation is farmer, and it is unilateral and acute. So with this picture we need to come to a common differential diagnosis, that is called, what is naming is nothing but unilateral acute non-granulomatous anterior uveitis, that is called naming of condition. Once we go into in that condition what all entities are present, then we need to go for meshing, like what are the possible differential diagnosis. We come to a finally come to the condition, and from then after coming to differential diagnosis we need to rule out by lab tests, like either we need to rule out or rule in through lab tests. And from there, if you suppose patient has any systemic condition, please don't hesitate to refer to a specialist, because either a pulmonologist or rheumatologist, they help us a lot. But one thing is, don't refer to them by providing a diagnosis, like I am thinking in terms of 2-year tuberculosis, kindly rule out. So they will tell us there is no tuberculosis, please you can start steroids. This is straightforward. So please don't go give them a diagnosis. Most of the chest physicians, they tell there is no pulmonary tuberculosis, you can go ahead with oral steroids, but they don't rule out extrapulmonary. So that we need to have in our picture, and from then we need to go for general and specific treatment. So with this example, what we can think of is ankylosing spondylitis. Patient has back pain. Leptospirosis, patient is a farmer. Ritter syndrome, he has urethritis. And Behçet's, he has oral ulceration. So all these conditions cause non-granulomatous anterior uveitis. So we need to know what all conditions cause non-granulomatous, what all cause granulomatous. So I will go through this. I think we don't have time with all these things. Yeah, child. Yeah, he has a 15-year-old, 12-year-old child. He has come with scleral nodule, and superiorly he has sclerokeratitis, superotemporal area. The tip and taking history, he had a father with exposure to tuberculosis, open case, and his MAN2 is positive. He had a positive MAN2, but chest X-ray is negative. With the history that his farmer is a known open tuberculosis patient, we need to go in terms of tuberculosis in this case. And tuberculosis typically presents with this type of sclerokeratitis, deep stromal keratitis, superotemporal, triangular, wedge-shaped scleritis. This is characteristic of tuberculosis. And there is a nodule as well. Patient was treated with ATT and is recovered completely, no recurrence. This is a case of, I think you can diagnose this. Yeah, VKH, bilateral, and this is the AV phase of pooling of dye. And this 15-year-old boy, history of fever 1 week back only for 3 days. He had pigmented granulomatous anterior uveitis with posterior cervical lymph node. And this is the picture, ARN. So this is a case of viral, he had a viral fever initially, and then that led to the acute natal necrosis. This patient present with pain right eye for 1 week, and pain has increased on eye movement. So other eye, there was an injury in childhood. So with this, usually what we do is we are towards sympathetic ophthalmia, but sympathetic ophthalmia is bilateral, and even the theiscal eye will be painful in the case of sympathetic ophthalmia. So this history is very important, whether really patient had one unilateral pain or a bilateral, and does he have any extraocular symptoms like headache, tinnitus, and all these things. So this patient, he has posterior scleritis and his MAN2 was positive. If you would have thought in terms of sympathetic ophthalmia, we would have started him on oral steroids, which would have aggravated the condition. Yeah, no, this is actually it's a serous retinal detachment. There is serous retinal detachment in posterior scleritis. Yeah, diffuse posterior scleritis, there is chance of serous detachment. You have seen, James? Diffuse posterior scleritis with serous detachments. So this patient has a diffuse scleritis, anti-scleritis. He had a nail infection, a nail bed infection. We thought in terms of fungal. Started him on oral antifungal treatment, but he didn't respond. Then slowly developed granulomatous anti-uveitis. Then we thought, we had a doubt. Done fundus exam. There is a lot of subretinal infiltrates, and then slowly other eye got involved. This eye has become theisical, and so we have done choroidal biopsy. It turned out to be lymphoma. So, I think the time is up. So I think we can stop here. Thank you.
Thank you, Dr. Venu, for this excellent presentation. Again, uveitis is something which is, I feel, even, pardon, sir? Correct. So it's what is there inside? It's very difficult, and like the last case that he presented, see, nobody would have thought suddenly out of the blue, and it turned out to be lymphoma. Good for the patient at least. Even though we lost one eye, at least we have the other eye saved. Thank you.
Scleritis. Yeah, posterior scleritis, as I said, patient will have pain on moving of eye movement. So that is one way is very, very, very difficult to diagnose actual posterior scleritis. Anterior diffuse scleritis. There are two types: diffuse and nodular. So initially, yeah, as any collagen vascular disease, the pain aggravates at night. So similar symptoms here also. And slit lamp, we need to differentiate from episcleritis and scleritis. That we can get by green filter. In slit lamp, once you put on the green filter, we can it will show the deep scleral vessels. If those picture dilated torches, deep scleral vessels.
All of us, can we just come up stage? We'll have a photograph.